Hello, I'm Richard Samelka, and today we're going to talk on the subject, is it time we obtained informed consent for CT imaging? So, as far as background, why do we provide information to patients to begin with? So the main arguments for informed consent revolve around protection, autonomy, prevention of abusive conduct, trust, self-ownership, non-domination, and personal integrity. The informed consent process arose in the U.S. from two court decisions in the early 1970s, one in California and one in Washington. And those cases held that there was a duty owed to patients by healthcare providers to obtain their informed consent, explaining risks, benefits, and alternative treatments. The failure to appropriately obtain the informed consent from patients is medical malpractice. So let's take a look at a couple of cases that achieved recent national recognition. Here's an individual who had undergone a CT perfusion study, and you can see the deterministic effect of radiation of hair loss in the pattern of the CT perfusion brain study. And here's another headline, another individual who underwent hair loss related to a CT brain perfusion study. So this is something clearly that has achieved not only medical but public interest. So the medical legal issues. For case law looking at Canterbury versus Spence, for reasonable decision making, the provider must disclose to the recipient of care any information that may influence the recipient's willingness to have the test. In fact, in Germany and Switzerland, they have outlawed procedures that use medical radiation for the simple purposes of screening. So let's step back a bit. How risky should a procedure be to warn a patient that there may be risks intrinsic to them? Let's take a look at common and known medical procedures. ERCP is associated with severe complications in 0.8% with a mortality rate of 0.08%. Laparoscopic cholecystectomy has a rate of serious morbidity of 1.4% and a mortality rate of 0.3%. Adverse reactions with IV iodinated contrast media are infrequent and range from 5% to 12% for high osmolar contrast media, and from 1 to 3% for low osmolar contrast media. Serious acute adverse reactions are rare and have historically occurred in approximately 1 or 2 per 10,000 intravascular injections of low osmolar contrast media. So, for me, a source document that has been highly influential in determining, at what level risk should be informed to individuals is a Veterans Administration directive from 2008 on disclosure of adverse events to patients. In this, they assembled a multidisciplinary advisory board involving physicians, nurses, other healthcare workers, medical ethicists. And they determined that disclosure to patients is required if the risk estimate for a procedure is greater than 1 in 10,000. Now, it should be noted that this was not assembled for the purpose of evaluating medical radiation, but I think it's reasonable to consider medical radiation in the same setting as other medical procedures, which is what that assembly of experts was determined to calculate that risk estimate. So, what if the risk of medical radiation, and does it fit into a 1 in 10,000 risk? And that's part of the problem. There is controversy over the certitude of radiation risk estimates, which no doubt contributes to the lack of general agreement that information should be provided to patients on radiation risks. And really the core of this controversy is the linear no-threshold risk model for estimation of radiation-related cancer risks. So let's take a look at this graph that was published recently by Picano et al. And I just want to draw your attention to this gold standard that many imaging studies are based upon, and that's one of the issues I think that many radiologists have issue with, is that this is the range of the A-bomb survivors and their risk for developing subsequently cancer. Now, most of the imaging radiation falls into this lower category, where dose here is related in sieverts. And I'm just going to highlight this portion of the graph in this next slide. Now, the linear assumption runs in this fashion, of course, in linear fashion. Now, if risks are greater, that would be above linear, and many radiologists would like to believe that in the lower radiation dose, and here we can see that this is at the 100 rad level, in the lower radiation dose, in the general imaging range, that maybe the risk is somewhat lower. And again, if we look at this other graph, this one is the conventional linear no-thresh model of cancer risk. This is a graph assuming that there may be a threshold, and this is now somewhat discredited, but with the concept that very low radiation may in fact have some benefit, which has been termed the Hermetic Model. And again, at this point in time, no reasonable scientist adheres to that. Now, this next image is a somewhat busy slide, and this refers to the effects of low linear energy transfer on mammalian cells, and which are dose dependent. Now, I'm not going to go over this slide, but you can retrace the presentation and take a closer look at this on your own. But bear in mind that most of what we're talking about is DNA damage, and the modern interest has been in double-stranded DNA damage as a surrogate for cancer induction. So, how have things changed over the years? Well, let's take a look at this graph, which describes reports that have been from the US in 87, the US in 93, from Germany in 1997, the US in 2006, and compared to the natural sources of radiation, where the red is radiology and the yellow is nuclear medicine procedures. And we can see with time, the number of diagnostic imaging studies, the radiation dose per population has increased to the present time, where the total man-made radiation exceeds the amount of natural background radiation. And this, of course, is alarming to many people. So the question is, what documentation should we rely on for information on medical radiation? And it would seem most appropriate to use the most scientifically validated data, and that's from the BEAR-7 report, which is an assembly of scientific experts from the National Academy of Sciences, and also what the FDA lists on their website. Now, they estimate that the risk of cancer occurs even with low radiation dose. Now, BEAR-7 and the reports of all major radiation societies follow the no lower threshold principle. Using their data, now looking at 40-year-old adults, most of their data are based on that. They estimate that one triple phase CT of the liver involves 10 to 20 millisieverts of radiation, and 10 millisieverts of radiation they associate with a 1 in 1,000 chance of developing cancer, which again is equivalent to one abdominal CT. And it has been estimated if there are 60 million CT exams per year, this may translate to 60,000 cancers. Now, the FDA on their website described 10 millisieverts associated with 1 in 2,000 chance of developing fatal cancer. I recommend reviewing both of those documents. So let's take a look at radiation dose per exam, and I think this is a very useful table to have in mind, and also to provide this information to patients if you are asked about it. And I want to draw your attention to the higher radiation dose procedures of abdomen, chest, pulmonary angiography, and PET-CT, which you can see are in the range from 10 millisieverts 10 millisieverts to upwards. Many people use a comparison as a chest x-ray, and we can see that that amounts to 0.02 millisieverts. And here are other procedures that are common in radiology. So this again is a complex table, and it may be something that you have to go back and look at. But starting with the radiation dose of MRI and ultrasound, which is 0. But in this table, Picano et al. Used a number of chest x-rays as equivalences for imaging studies. Now, it may be useful that some people may like the conversion to the number of chest x-rays, and it seems not unreasonable for chest CT to talk about that. And here we can see the figure they derive is 400 chest x-rays is one chest CT. So, looking at this particular graph, this looks at another graphic display of risk of cancer related to the equivalence of chest x-rays for some common radiology procedures. Now, off the top of the charts is a thallium scan, but in the territory that I deal with, which is abdominal CT, you can see that we're right in the range of about 1 in 2,000 chance of developing cancers from one procedure. Now, to me, this is perhaps amongst the most important information that one has to understand, that the attributable lifetime risk for a single small dose of radiation is strongly related to age. And I want to highlight, where red is female and blue checkered is male, that females, particularly in the very young age, are at very high risk of developing cancer from medical radiation exposure. And interestingly, it starts tailing off and becoming somewhat flat at the point that many of the tables describe the radiation risk, which is at the age of 40. This is another graph that displays cancer risk per age, and again, I think just appreciating the shape of the columns, you can appreciate at the very young age the risk of cancer is much greater for the same radiation dose compared to as you get older. Where again, in the range of 25 to 30 is where we start seeing a sizable decrease in the risk. So the problem is that many experts harken back to, and it's not been unreasonable, is that most of the data that we use evaluating risk from, say, CT studies has been from data derived from atomic bomb survivors. Of course, that ignores the fact that gamma rays and X-rays are relatively equivalent in their cancer induction possibilities. But that aside, there's a relative paucity of research looking at CT scans and other medical radiation studies directly. Well, here's a study that was published in the CMAJ in 2011, a large study based out of Quebec, in which they had a cohort of greater than 82,000 patients who underwent, who were cardiac patients who underwent a number of cardiac imaging procedures. 77% underwent at least one cardiac imaging or therapeutic procedure involving low-dose radiation. Now, they estimated from their study, and they had a follow-up period of, again, I would say only 5 years, when we understand that the risk goes well beyond 5 years, certainly up to 20 years and beyond, with perhaps 20 years being an appropriate cutoff. So one could, in fact, suggest that their estimates are even modest. But they claim that for every 10 millisieverts of low-dose ionizing radiation, there was a 3% increase in the risk of age and sex-adjusted cancer over that 5-year period. They also suggested that exposure to low-dose ionizing radiation from cardiac imaging and therapeutic procedures after myocardial infarction is associated with an increased risk of cancer. And this, again, is now finally data based on a large population where they observe this risk. Now, taking tables out of that paper, and again, these are somewhat complicated, so I may advise you to look at these tables yourself if you want to analyze it more closely. But they talked about the mean effective radiation dose for various procedures and the percentage of all low-dose ionizing radiation from cardiac imaging in general, and the number of patients that were in those categories. Now, this is their risk estimates from decreased risk to increased risk. Again, a complicated table. I advise you, or recommend you, that you look at the original source, but I want to address and draw your attention to these categories here, where for 20 millisievert increase up to 40 millisievert increase, we saw an increased risk, especially adjusted in these subjects. So where do we currently stand as far as providing information to patients? Well, in 2004, a landmark study was published in Radiology in which they described that 7% of patients reported that they were informed about risks and benefits of their CT scan. Well, very recently, published in JAMA, a 2013 study, which was a survey of 271 patients, a majority of the respondents believed that the final decision to undergo CT was mainly the physicians, 62%, and we certainly as radiologists can well believe that figure. And a minority said that they had discussed with them the potential risks of the test with their healthcare provider. Well, 35% still seems low, you could say, but perhaps an improvement from 2004. And in the meantime, much more information and many more programs have been initiated. So one could look at it both as a positive, that there is improvement, but also as a negative, that I think we could still do better than that. So where do we stand? And this again is from that study. And we look at the number of respondents and what was the risk of having a CT study. 24% said that there was low risk, and a relatively small percentage were informed that there may be a radiation risk associated, radiation and a cancer risk, 5% associated with this. And 5% is perhaps a low percentage for information that there may be cancer associated with CT. So if we can assume, and it may seem a reasonable supposition, that patients should be provided information, and I think that we would all believe if there was something that was associated with reasonable amount of risk, it seems self-evident that we would want to be informed of that risk. Well, one can, as a next step, to determine that information should be provided. Then how do we do that? Well, up to the present time, most of that information provision has been, I would call, passive, which is we're not actively providing the patients with information. They're deriving it from themselves, from their own research online or by other sources. Now, I think we have to engage in active information. And the question is, how should we do it? Now, the simplest is some sort of distribution of information to patients by either an email or by a brochure or something. And at a minimum, I think something like this should be done. Something like information provided to the patient by brochure form at check-in, or again, as we move to perhaps online notifications to individuals and online notification of risk benefits with, again, not only benefits mentioned, but also risks mentioned as well. Now, information verbally conveyed to patients, this is termed verbal informed consent. I think it's reasonable to think that this should be performed in higher radiation dose procedures. And by that I mean 1 millisievert and above. And finally, what's termed written informed consent, where information is presented to the patient and is memorialized in written form. Now that, of course, is a subject that makes many of us somewhat nervous because of the amount of work and the time delays that may be involved in a procedure like that. But clearly, something has to be done, at least in these two first categories of providing information to patients. I think that we would want to be informed of anything in which reasonable scientific organizations consider the risk to be not insignificant. So, in conclusion, it would seem appropriate that patients be informed that medical imaging carries with it a risk of cancer induction. As I just mentioned, and I think you'll hear much more of this through the course of lectures, that virtually all, if not all, major radiation societies adhere to the linear risk model with no threshold for cancer induction. And from my understanding, the work that I've done in this, I think that 1 millisievert is maybe a reasonable level to inform patients of this risk, and 1 millisievert translates very nicely to most CT procedures. And interestingly, as we move to having, if you like, a threshold of patient information, it really has, and we've seen this in recent years, that many advances have taken place in CT, that the estimates that I've shown you of 10 millisieverts for abdominal CT, many new approaches, that amount of radiation delivery for most CT procedures is dropping dramatically. And I think we have to credit both radiologists and scientists associated with radiology and equipment manufacturers with that push to reducing the radiation. And in fact, if 1 millisievert is mandated at this level, that would be a pretty good way to get even greater efforts done at reducing per procedure to patients the amount of radiation they experience. Because we always have to remember, and I think all of us adhere to the concept, that ALARA is important. And I think the two of them can work together. The requirement for information at a certain threshold and the efforts made to go below that threshold for common radiology procedures, again, mainly on the basis of ALARA, but also avoiding the kicking in, if you like, of something like written informed consent. And I think it's also appropriate, I think we all, to a greater or lesser extent, fail at this, is describing to patients that there are alternative methods available to them, such as ultrasound and MRI, that don't require medical radiation. And with that, I thank you for your attention, and I wish you all the best with your efforts in providing patients with information and reducing the amount of radiation